Hello and welcome to this week's HealthTech Hour with me, Steve Roest. Each week we bring you the best news, views and interviews with the CEOs, founders, leaders and clinicians who are changing the world of healthcare in the UK and beyond. I am a founder and CEO of a health tech business myself called PocDoc. Regular listeners will know that PocDoc is a big supporter of the show. PocDoc, we are revolutionizing the way you can access a blood test by allowing you to do it with a smartphone or tablet, delivering digital health checks focused on cardiovascular disease predominantly, designed to increase access to testing, which is actually quite topical given today's guest. Is also, different space but similar mission, which we will get to. So we've been away all summer. It's been wonderful, and now we're back at it. It's great to be back on the radio live. So hello to everybody. I hope that you all had fantastic summers. Hope you listened to a lot of UK Health Radio along the way. It's great to be back live. There's just a difference. There's just a different feeling about being able to be live. I love it. The producers of the show, we love it too. So it's great to be here. We also just did a quick check of the number of countries that listen to the show and download the show on a monthly basis on the podcast channel. So that's Spotify, all of the others. We're up everywhere. And it's now up to 45 countries that download the podcast, which is kind of insane. So since this over the summer, we've added places like Kazakhstan, China, Morocco, and the Philippines to our listener base. So hello to everyone listening from those locations. Thanks for joining. Thanks to everyone who's watching on YouTube. And thanks to everyone, obviously, who's listening live on UK Health Radio. We love Johan and the team. And also just one final piece of admin, and we can get into the show. Every single UK Health Radio show, every single one, is available on the UK Health Radio podcast channel, which is on all of the podcast platforms. So you can get our show directly through the HealthTech Hour channel, or you can get our show and all of the other great shows that UK Health Radio puts out on their own channel. So welcome to the only and therefore leading live health tech show on the radio. That's us in the world. So on to today's show is really topical, completely by chance, but very topical given which many of you may have seen. It was in the news, all over the TV, all over the newspapers, about a trial. UCL, University College London, just published results of a trial comparing the success rate in finding prostate cancer between having an MRI scan and a PSA test. So PSA, prostate specific antigen test, is a blood test and generally considered to be the default option in screening men over 50 for risk of prostate cancer. So generally speaking, the acceptable level, the healthy level of PSA is somewhere between 3 and 4, depending upon which guideline you use. There was a big trial that they looked at, which published its results today, which showed that actually using an MRI scan was a lot more effective in finding people with prostate cancer, men with prostate cancer, and actually found a number of men, 16% of people in the trial, which is a lot of people in the trial, who actually were discovered via MRI to have prostate cancer. Their PSA blood test was actually negative or below a level that meant if they'd have just had that PSA blood test, their cancer would not have been found. Now, the big questions that this opens up, and to be fair to the people who run the trial, as well as NHS leaders and other healthcare people, the big question is the feasibility, ultimately, of running national screening using MRI on men over 50, given the way the health service is and given the fact that MRI scanners are not exactly small, cheap pieces of equipment. But I think it's a really interesting segue into our guest today, who is Brian Plackis Cheng, who is the CEO of OpenRad. Now, OpenRad is a remote radiology platform that is aiming to massively increase the efficiency and access to high-level scanning, X-rays, MRIs, all completely remotely to try and, I would imagine, make it easier, faster, quicker, more cost-effective, and ultimately more successful for patients to diagnose and therefore receive treatment for things. So it's very relevant given this study, and also more widely through the issues that have been widely publicized in the UK, at least, around backlogs for scans and access to scans and all these kind of different things. So Brian, welcome to the show. How are you?
Great. Well, thank you very much for having me. And like you said, very topical today, talking about imaging diagnostics. It's great to be on your show, and I really appreciate the stories that you're telling. I think in healthcare, we really want to figure out how to innovate faster and take advantage of all the new tech that is available, and how do we overcome some of the institutional challenges and some of the healthcare system challenges that essentially slow down or limit access to this advanced imaging. So thanks again for having me.
No, it's welcome. We love, we've not had anyone really from the imaging sector, if you like, on, and certainly no one with your sort of mission. So let's like back up the truck slightly and go straight into something that you just mentioned, which is like um, this idea that healthcare is hard or health tech is hard. So it's something that gets thrown around a lot, obviously, and I guess there are different reasons for it, but what is it particularly that you view as some of those obstacles and challenges, and in
Yeah,
your view, and then
so,
we
so
can
I'm a
kick that over.
technologist. I've spent most of my career in internet technology or cloud-based technology applications that run on servers in the cloud or in the internet. And obviously, there's many barriers or challenges on adopting innovative cloud technology in the healthcare space. You see so many innovations happening. There's rapid advancements in AI, for example, right? And how do we apply these tool sets to the imaging space, right? And what are the barriers that are preventing that from happening? And a lot of it has to do with the inertia of the infrastructure that's there today, right? A lot of the software that's utilized in healthcare are legacy systems that could be 8, 10, 12 years old. They run on premise, and they weren't designed for this like open, collaborative, adaptive tech world we live in today. And it's not an easy lift to basically pull these systems out and replace them, because they're mission critical to public networks, healthcare networks, to
And
hospitals, to clinics that run
yeah,
them.
are
And
you
I call
able
that
to,
inertia, right? So
are you
that's the
able to even like to that point? We'll get into imaging and what that means and everything in a second. So don't worry, listeners. We'll unpack all of that. But just to the point that you were making, like there's these big giant machines, whether it's an X-ray machine, an MRI. I mean, if anyone's had an MRI, I'm sure lots of people have. That thing is a beast of a machine in there. I mean, that really is a behemoth in there. I'm sure it will get smaller and so on and so forth, but right now they're pretty big things. So the software that you're saying that runs them is effectively kind of embedded, right? And it may be a bit. So are is it fit for purpose, as in theory can it be made to integrate with cloud things, cloud systems, or is it just a no hoper and it's sort of you got to strip it all out and then you take an MRI scanner out of action for goodness knows how long, and where are we with that, do you
Yeah,
think?
so a couple things, like if we were to break down some of the barriers, right? One is the legacy software that basically does the sharing and the collaboration and the reporting of the images. That's clearly one piece. You have storage systems, they're called PACS systems, and I'm happy to spend a little bit of time and walk your audience through it. But that's a picture archiving and communication system. That's where these digital images are actually stored once you do a scan. So you have these expensive machines that you're talking about, and there's obviously set up in centers. More and more, they're in clinics these days. You used to have to go to a hospital, but more and more we have like community diagnostic centers, and not only can you get blood tests or X-rays, but you can get MRIs as well. And once these images are created, they're stored digitally on the machine. And you think of like maybe like a scanner in your house stores things in PDF. In the imaging world, they're stored in DICOM. So
Okay.
DICOM is like the standard format of images, similar to like PDF, right?
Okay.
And they're very complex, three-dimensional images with slices in
Yeah.
them. If you can imagine, there's also metadata attached to that DICOM file that might have the patient record, what machine took the image, operator information, etc. And that's all passed along the image. It's picked up at the scanner and then sent to a PACS, a server
Okay.
somewhere, and then that image has to be accessed by a radiologist, where they're
Yeah.
actually going to do a report or a diagnosis of the image. And so there's many places to introduce technology friction in that food chain.
And so, like, is there? I feel like I love this. Is exactly why I love doing the show, because we just like dive straight in. None of the journey, none of that stuff. Let's just get straight into it. So is it normal? And I guess our normal listeners will understand that I do this sometimes. So here we go. One of the reasons why you listen to the show, I guess. The Is it normal that one provider would provide the hardware, i.e., the scanner, and then the subsequent software journey across all of those different bits and bobs, versus providers coming in and being able to say, right, I've got a better storage solution, I've got a better viewing and diagnosis solution, I've got a better radiology, viewing platform, so to speak. What normally happens?
That's a great question. So if you think of like the evolution of tech, typically at the early stages, you have the main provider, say it's Siemens, Canon, Philips, GE. They provided a turnkey solution, and
Yeah,
obviously most of these companies are hardware companies, and their specialty is really these magnificent feats of engineering, right?
yeah,
These diagnostic machines. Um, but typically software really isn't their expertise, and so maybe the version ones of the solution are not full featured. They are obviously aren't cloud based. Maybe they didn't handle AI capabilities.
yeah,
Maybe people couldn't access the image when they were away from the facility, maybe in their office or at another site. And then over time, you started getting specialists in each of these areas. So you got, for example, in the area called RIS, and a RIS is a radiology information system. It's kind of like a CRM for patients, of a whole segment developed around patient records, right? And
yeah,
a whole segment developed around a PAC. So this is the storage system. And where we really focus is a new area. It's really the workflow systems. And what's really cool about our approach is that we can basically add a layer of software on top of these legacy systems that bridge them to the cloud. So you don't have to throw everything out. You don't have to get rid of all that storage, but we
yeah,
can add workflow and collaboration software that sits on top of these systems, connects them all together. You might have a Siemens over here, Philips over here. You might have one RIS vendor over here, a different PACS vendor over there. And we actually are the glue that connects those systems and allows people to collaborate irrespective of the underlying technology. And so this is like an evolution that happens, I think, in all different segments. It's kind of the third wave where you
yeah.
have these integrators come in and add workflow that works across disparate systems.
That makes sense. Yeah, I think you see that cycle in different areas. And I guess the point that you're making is that in healthcare it's slower, that movement through those cycles. So you don't get to the point in phase two or phase three where you have real people focusing on very specific parts of that value chain or patient chain or workflow or whatever you want to call it, to really create a best in class service for that particular thing.
That's right. So you have a couple issues, right? So one issue is, obviously it's not in the interest of the incumbents or the legacy providers to really open things up and make that easy. Now,
No.
there are standards like DICOM we mentioned for images. There's another standard called HL7, which allows the integration and exchange of data between these different systems. And so once you have some standards, like think of like email, you have this thing called SMTP, and it
Yeah.
makes all the email systems talk to each other. HL7 does a similar type of function in the imaging world. You now can put software that can collaborate and access confidentially patient records across different systems. So if you went scanning to one center, but you show up at a different clinic to get your diagnosis, that doctor may want to pull up that report, but also maybe priors you had at other facilities and bring them all together. And our software enables that type of image sharing, and then of course collaboration not only with the patient but maybe with a specialist or a referring physician.
Okay. And all of that together sort of does what's the big so what that really helps
Yeah,
deliver.
so if you think about the big challenge, obviously there's capacity of the machines, right? Are
Yeah.
there enough slots available? Think of like planes flying. The MRIs are like airplanes with seats, and
Yeah.
each slot is a seat on the airplane, right? So obviously you need the cost of those machines to come down, so that there's more of them. It's more inexpensive. It's cost effective to get the scans. That's the first thing. The
Mhm.
second thing, though, is you need people who can actually do the diagnosis, right? And so,
Yeah.
obviously, as you're increasing the number of scans, you need to increase the number of people who can do reports or make that much more efficient so a single expert can handle more and more reports in a given period of time. And
Hmm.
so our software is essentially the glue or the rails that allows you, say, for example, you're a radiologist who works at a hospital, but maybe after hours you want to pick up, some extra money, but also do some extra reporting. You can now work at 6 and 9 from your home and get access securely to an inventory of scans that are awaiting diagnosis. And in the
Okay.
old days, you had to physically be at the hospital or at the clinic. Now we can basically have an inventory of scans that need reports and make them available to qualified radiologists, irrespective of location.
That makes a lot of sense. That makes a lot of sense. Because why does a radiologist have to be in a physical location to look at a scan, in effect? So that makes sense to me. So just to go back a couple of steps, when we talk about imaging and radiology and so on and so forth, it includes what? X-rays, MRI.
MRIs, right? CTs, exactly, right? So,
Yeah.
exactly, right? And it's an interesting, it's an interesting discussion. You talked about the news report today. What is the best type of diagnostic tool? And one of the challenges is sometimes a better tool seems more expensive because the initial cost is high, but maybe over the overall, during the entire care cycle, maybe having a better diagnosis earlier not only gets a better patient outcome, it also might be much more cost effective, right? And these are the kind of things we're working through. PSA is a good example. People with prostate cancer, they've had false positives for years.
Yeah.
And then obviously, right? And you get yourself all worked up and then you have to go in.
So we at PocDoc we looked quite hard at PSA. We still get asked about it all the time, actually, from various different people. And for the false positive thing for us was just we just couldn't really get can't get past it at this point. I think it's just and again for everyone listening, those of you that may or may not be experts in PSA and prostate cancer, and Brian, jump in if I get this wrong, but historically the issue with the PSA test is that having an elevated PSA, prostate specific antigen, doesn't necessarily mean that you have prostate cancer. So there are individual fluctuations. There are fluctuations longitudinally, i.e., over time. Um, the kind of and so that has created people getting their PSA tested has created potential false positives. So people that thought they might have prostate cancer but didn't. So different stats fly around, but some of the tests claim something like a 50% false positive, right? So I think where we came at it, which again, we would not do anything, I don't think, until we had pretty solid clinical backup on this, particularly not in light of like news stories today, right? Where you'd have to feel pretty confident. Would be like some kind of longitudinal tracking of PSA, so that you could establish, well, look, if someone's baseline is this, then elevation of X above baseline would be cause for concern. But just like spot testing, yeah, it's problematic.
Yeah, I mean, you can also trend over time, right? So ideally, maybe you're getting data points that are painting a picture over time, and obviously, we don't want to deter people from getting these diagnostics. But in a perfect world, right, we would be able to get access to the right type of diagnostic, and the cost and accessibility wouldn't be an issue, right? And so, clearly, our mission, right, is to really drive the affordability, the accessibility, the quality of diagnostic imaging so that we can lower the barrier to using it in more of these types of use cases.
Yeah,
Exactly.
I think that makes a lot of sense. So we are going to stop for a break now, first commercial break, and then we'll come back. And then when we come back, Brian, I want to jump into this area around backlog. So I know that you guys are based in the UK and Germany, I believe. And so there's obviously a huge amount of, and it's been going on for ages, around the NHS backlog, which is going up, not down. And I think diagnostics within that, in the broadest sense, is one of the areas. And I want to sort of understand your view on the backlog around scans, and also trying to understand, like, because I think that there's still a real misunderstanding around why it exists and why it takes that long and what happens and the issues around scheduling and the complexities and all these different things. So I think it'd be interesting to kick that around, if that's okay with you. Not that you can go anywhere, but I figure I'd make it look like I was asking.
Sounds great.
All right, great. Well, we'll be back in 2 minutes after this short break. Hello and welcome back to this week's HealthTech Hour, our first HealthTech Hour back live after the summer break. with obviously myself, Steve Roest, CEO of PocDoc and host of the HealthTech Hour, and my guest today, Brian Plackis Cheng, who's the CEO of OpenRad, which is a next generation diagnostic radiology platform, cloud-based platform to increase efficiency and workflow through better access to imaging. So, Brian, before the break, we were kind of digging in and around some of the structural issues and trends in this space around radiology and imaging, and I said that I wanted to dive into this area of backlogs. So obviously, it's been in the news for a really long time, headline around how difficult it is to get seen, scanned, diagnosed, etc. What's your view from your particular point of view, which is obviously radiology and imaging and things like that? What's your view around how it's going and some of the reasons for that? Maybe some of the things that people don't really understand about why there's such a backlog?
Yeah, so if you look at the kind of the value chain of imaging, obviously the first issue, right, is just having facilities that have availability that are nearby, right? And so there's obviously been a big shift over the last 2 decades, depends what market you're in, moving from like a hospital would typically have an MRI, they're really expensive equipment. You need to have some skill to maintain and operate them. And over the last, say, decade or so, in many countries, we've been moving to more like community diagnostic centers or clinics where
Mm-hmm.
now you can easily get access to imaging, expensive imaging hardware in an area nearby, relatively convenient and comfortable, right? And so the first aspect is just is there enough capacity with these expensive devices, right? And each country is going through a different type of adoption curve and availability around the machines themselves, right? And that's obviously the facilities, the hardware. You obviously need expertise in terms of operating that machines. You need technicians, etc. Once that is all in place, you still have another barrier where you need experts that actually can diagnose those images, right? And so
Right.
those images are getting generated. You might have in a given center on one machine, I don't know, maybe 2 an hour, 3 an hour. You're generating, say, 20, 25, 30 or more images per day that need to be diagnosed by an expert, right?
Mm-hmm.
And so the next challenge is, do you have sufficient capacity in the medical system with doctors that are credentialed and that for that specific area, that specific facility, to basically tell you what's going on with your image, right? And
Okay.
this is the second area of backlog, right? So the first is just access to the physical machines, having enough machines. The second one is having enough radiologists that can do the reporting. And this is getting compounded, like say countries like Germany, which historically have uh, had many qualified radiologists. They're retiring, and what's happening in the pipeline is people are afraid that AI is going to take their jobs, and
Oh,
so
really?
you're starting to see this phenomenon. And I think it's something we really need to push against in the industry is that AI is not going to take these jobs. AI is going to be a productivity enhancer. It's going to be
Yeah.
a multiplier, right? So when you talk about, the backlog, there's several ways to solve the backlog. One is to get people obviously that are available but not physically near the machines to be able to do remote reporting. And
Yeah.
so a big mission of our company is to make it very easy for doctors, no matter where they are, as long as they're credentialed and qualified, to be able to do reporting anywhere at any time on just about any device that has the required high resolution monitor. And what's really great about this is once these images are in our cloud, we stream them like a Netflix movie. You don't
Right.
need any special software, and suddenly now a doctor who's available that's credentialed can now get access and do a diagnosis. And so what we're trying to do to solve the backlog is one, bring more people into into the work resource pool. That's one
Yeah.
aspect. Also, potentially, some of them can work, and it depends on which markets this is allowed, as freelancers, and then they can work off hours on the weekends or the evenings, and that can be extra capacity or extra labor supply. And there's
Yeah.
actually some places where they're doing tests where they're leveraging resources in other countries as remote. And again, having workflow that runs in the cloud is really the key enabler.
And what uh, there are obviously going to be people, healthcare systems that are further ahead and further behind. But is it sort of, do you think that there are enough radiologists in the system to do is look, because what you're talking about there is effectively evening out, smoothing out the supply and demand, deference or delta, which makes sense, right? You've got, at some point you've got more radiologists with availability over here and more scans over there, and you can sort of pool it, which makes sense. But do you think that there are enough radiologists in the system to be able to cope as long as you allocated resource more efficiently?
Well, I mean, if you look at the productivity of radiologists, it's all over the place. Like you have people that are just that are doing high volumes of reports every day. You have other people that are doing lower volumes. How much of that is preference? How much of that is access?
Right.
That's not entirely clear. But what we want to do is make it so that access is not an issue, right? And so no
Hmm.
matter where you are, if you're qualified and credentialed, you can do the reporting. And that is the first barrier that can get removed. The other barrier then is obviously productivity. Can you give tools that actually increase productivity? For example, can you improve the quality of the image so that you kind of defog or make the image more clear? Can you provide tools that are easier to use, that have a better user experience? And this is where I think AI is really useful. Can you perhaps do a pre-process or a first pass with AI so you can flag artifacts and kind of pre-populate? And
Yeah.
so the radiologist can do like a final review and a final report and not have to do so much of the keystroking themselves.
Because there's a huge amount, I mean, obviously a huge amount of funding and a huge number of people who are in this space of AI, particularly MRI, image analysis, AI diagnosis, and all of them seem to be publishing positive results. I guess they probably wouldn't publish results unless they were positive. So you don't know what you don't know. But um, is do you it sounds like your view on those is that yes, that's all well and good, and yes, that's great, and that's definitely like net positive, but it needs to be incorporated into a system where we don't exclude human qualified people.
Yeah, I mean, I think one, obviously we're still in the early days, but we're seeing really rapid advancement in AI. I'm sure as a consumer, everyone's familiar with like ChatGPT
Yeah.
and what's happening there. We're seeing similar type of development on the in the medical field as well. The challenge there is the use case, right? Because, for example, one use case is if you have a backlog of images, maybe you should focus on the images that are highest risk, right? That are potentially most problematic. And if
Yeah.
you can use AI as like a triage and go through the backlog and identify the images that really need attention, that already can really help the system focus on the people that need urgent attention, right? So that's an example of a use
Yeah.
case of AI. Another use case, like I said, is doing like a first pass, right? So in that scenario, you basically have kind of a smart reporting capability where the AI is actually going in, identifying the artifacts, and then perhaps making a set of suggestions or recommendations that could be reviewed by a human. So that's a second use case. A third use case could,
Oh,
oh,
go
go
on.
ahead, I'm
Sorry.
sorry.
No, go ahead.
A third use case could be like a quality control, where you're using the AI to kind of do an audit or a review, right? To just kind of do a check to make sure that all the fields were filled out, or at a high level, do we feel like this was an accurate diagnosis, right? So this is another use case. The challenge with AI, though, is for each, whether we're doing, say, lung or brain or breast, they need different algorithms, right? And so the challenge, if you're selling AI technology, you need a way to aggregate large numbers of images to one place so you can apply these different tools to different types of images, right?
Yeah.
Um, and so you'll have maybe if you have a collection of 10 tools or 20 tools, you have to make it really easy to plug those tools into a
Yeah, right.
platform,
Yeah,
right?
you can't be asking or expecting people to go out and figure out the right tool. Like, oh, I'm doing breast cancer today. I need to find the breast cancer AI. Like
Exactly.
you can't be doing that. Yeah, I hadn't thought about that. That makes total
So
sense.
that's where we can, once you start putting this stuff in the cloud, then we can be kind of the mediator between the AI tool vendors and the radiologist, and we can figure out based on the tissue type, what tool is appropriate, apply that tool, and we can actually run it before the radiologist even brings up the scan, right? And so
Yeah.
these are one of the advantages of having, the reports, I mean, the scans in the cloud.
Yeah, and like it all kind of flows back through. So this is another kind of thing that I think maybe it gets a bit overlooked. I don't know, but we've certainly sort of circled like people have mentioned this to us a little bit, which is sort of why don't you use more AI in what you do, sort of thing, right? And where we all keep coming back to is like, well, if that AI forms part of a diagnosis, that AI is a medical device. So you then need to go through the process of registering it as a medical device, demonstrating it, and that process. There's an element of particularly with these LLMs where it seems to be hard to be able to work out how the black box in the middle works, which is kind of problematic for regulators. You know,
Exactly. Yeah.
like
Yeah.
you can't. Well, as the way I'm not a regulatory expert, but I've been through it quite a bit. The way I read it is like you can't really say that it's a black box. You need to be able to trace an input through to an output, and then in reverse, an output
Exactly.
back to an input. Like you can't just be like, well, 98% of the time it seems fine, but we're not really sure why.
It's almost like you need another expert telling you what they see, right? And
Yeah,
so, right, and that's why it's quite difficult, right? And so when we talked about this idea of the backlog, part of it we talked about was the imaging devices, the centers, the capacity, the slots that are available, right? And that's one part of it. The other part of it we talked about was the radiologist, right? And one, if we decouple the location so the radiologist can be anywhere, obviously they have to be credentialed, qualified and credentialed, then you can tap into this resource pool irrespective of location, right? And that can be really important, for example, in an emergency room where you might need access to a specialist after a car accident. You're not going to keep all these specialists available, but they might be on call, and then suddenly you can bring them on and let them very quickly get access to an image that's already been streamed up into the cloud, right? And so this is really
yeah.
important to be able to access. The
Do
third part we
you?
talked about is
Yeah.
driving productivity, right? Is
Do
like,
you feel?
how
Do
can
you?
we make the doctors more efficient
Yeah.
so that we don't just need more doctors, but we can help them be more productive. But
Well,
then the
also
other
like
element is at
if
higher quality.
if your plan is to hire more doctors and more radiographers and more radiologists, like that's not a quick plan. Like
That'll take years, right?
yeah, I mean that's a big. I mean, my mum was a radiographer for 30 years in the NHS, and she towards the end of her time there was already. This was she probably retired. She won't thank me for saying this, but probably 10 years ago, and she, even then she was communicating to us and us about how the difficulty in finding entry level radiographers and people to come in at the bottom that would then move up, right? Like, so if you don't have anyone in the bottom, then obviously you're not going to end up with anybody at the top. So one question I have is if this idea that so we come across it before on the show in a different space with a business called Locum's Nest, which is founded and run by an amazing guy called Ahmed Sharabani, who's been on the show a couple of times. And they are a workforce solution, NHS workforce solution. He's a doctor. And the main challenge that they were trying to solve for was that in one NHS ICS trust, there was a surplus of a particular type of clinician. But then literally across the border in the next county, there was a deficit of that particular type of person. But because of the way that the contracts were set up, that person was unable to go across and work in that, even though it might be 10 miles or 5 miles, all within the NHS. So that was a long running battle that they eventually won through. And so I guess that leads me to my question now, which is how set up do you believe the healthcare system is in any country, pick a country, not trying to pick on the NHS at all, open to this idea of that sort of workforce, flexible, remote type solution in this space? Because it made complete sense to me, and I could see it being a big selling point to try and get somebody into this area, or to try and improve someone's work-life balance, or however you would phrase it, right? I think it's a great way. I'm just not sure quite how receptive they might be at a
Well,
system level.
typically they require a kind of a middleman that acts as a credentialing agency, right? So
Okay.
there's a huge field called teleradiology, and
Oh,
this
okay.
has
It's a
been
big deal already.
around, yeah, for decades in the UK. The UK is actually a very, I'd say, a leader in this area. really opened up the ability for people who might have a primary job at a certain facility to sign up with a teleradiology firm after hours, right? And then the
Cool.
question becomes, so the teleradiology firms, they're our clients, right? And they need a platform that can integrate and connect to all these different hospital systems, these MRIs. And then what's really cool is they put the radiologist on the platform. We have an inventory of work that gets sorted or filtered by their credentials. And then
Right.
based on their availability, they get assigned work based on there might be a criticality, how urgent it is, or maybe there's an SLA that says it's due in 48 hours. And we make sure that a qualified doctor gets to it within the SLA, right?
Okay.
And then, like you said, there could be different contracts. You don't want the radiologist to know where care on this contract, the reporting format looks like this, and in this
Yeah.
contract. So we take care of all of that, right? And
Right.
we're particularly adapted dealing with the flows across organizational boundaries. So maybe there's a scanning center over here, you're sending it to a hospital over here with a radiologist over here to a referring physician in another city, right? And we can help that image get shared, diagnosed, and collaborated across that complex network of providers.
That makes sense. So do you think that right now that there are enough, because there's obviously still a backlog, and so is it around just is the bottleneck the number of machines or the efficiency of booking people onto the machines, or is it just the sheer volume of people, or is it the kind of where those having enough radiologists to view those reports and make the follow through to kind of clear the pipe?
Yeah, there's no like one bottleneck in the
Sure.
factory. It's like an all of the above kind of problem, and so you
Yeah.
really have to tackle it. So if you look at like appointments, right? There's different companies out there that now help you search on the web. Like for example, in France and Germany and Italy, there's like Doctor Lib, for example. I think you have Scan.com in the UK, and they basically help patients find slots and centers, right? And
Yeah.
so that's a good example of technology making that easier, lowering the scheduling friction. So that's one example, right? Ideally, your information gets populated into that RIS system, that patient information system. You show up at the center, you do your scan. We have the ability to pick that up and then route it, say, for example, to a teleradiology firm that's outsourced, is hired as a reporting agency on behalf of a hospital or a clinic that's actually doing the diagnosis, right?
Yeah.
And I would say that is obviously the machines are expensive, but you can build more machines. Obviously, building facilities isn't cheap; it's not fast, but you can do that. Say at 5-6% per year. The challenge has been obviously with radiologists. Not only do we need more of them, we also have people retiring, so we have to replace them as well, right?
Yeah.
So in the short term, being able to access radiologists and radiographers remotely is greatly extending the resource pool, right? So that's one aspect. The other one is time shifting. If they can work off hours or on the weekends for extra money, that's another way of increasing the pool,
Yeah.
right? But ultimately, we have to bring more people in. And so
Yeah.
I want to send love to the radiology community and say, look, this is a great field. Don't be afraid of AI. AI is going to help make you more productive. It's going to help you be more impactful. It's going to help you have better quality. But it's not going to take your jobs away anytime soon.
Yeah. I think that that's like if that's I didn't realize that there was already evidence of people selecting out of a career in radiology due to fears of AI. Because that I mean that's wildly the wrong interpretation there of that. So that's kind of like a law of unintended consequences about everyone getting very excited about AI, which is it kind of puts people off even bothering to apply, which then creates all kinds of problems.
Well, a good example is like in software development, right? People say, well, AI is going to take software developers' jobs, right? And the truth is, it makes developers more productive. Some developers say they're 3 times more productive or 5 times. But the truth is, we don't have enough developers. If you look at job shortages, there's simply not enough, right? So
Yeah,
even if you get 2x or 3x, you're still not enough, right? And I would
yeah,
say in reporting, it's the same thing, right? So, if we make you 50% more productive, that's still not going to be enough to handle like you said, if it turns out that MRIs are giving better diagnosis than PSAs, and we can bring that cost point down, we're going to do more and more scanning, right? And we're going to need more
Yeah,
and
like
more people. Right?
imagine if like suddenly they're like, right, we want to do a national PSI, a national, everyone over, men over 50 get a MRI scan once every, I don't know what it would be, I'm not sure, 5 years, I've no idea what would be sensible, 2 years, right? There's a lot of men over 50 in the UK. That's a lot of scans on top of where we already were, right? And then suddenly they'll figure out that there might be another program to do this and to do that and to do that, and it's just you would want, if that's the right clinical solution, you would want that to be feasible and not be prevented because of non-clinical issues,
Exactly. Yeah.
right?
Yeah.
That would suck, basically.
I mean, in a way, that's kind of a tragedy, right? That where you have the technology, but because it's expensive or there's a limited supply, it's becoming a barrier to providing better care, right? And I think a big part of innovation in almost any industry is over time you want to ride that cost curve down, right? Because technology gets cheaper over time. You apply better production techniques, you get new technology approaches, you get better software, you have AI, all those things bring down the cost. And we want to see the medical, industry benefit from that cost curve, right? And as
Yeah,
we do, then you can use imaging more and more as a better diagnostic tool.
makes sense. Right. My producer's yelling at me. We have to go to the final commercial break of this week's show. So we will be back in 2 minutes with my guest today, Plackis Cheng, the CEO of OpenRad. We will be back in 2 minutes. Hello, and welcome back to the final part of today's show with me, Steve Roest, CEO of PocDoc and host of the HealthTech Hour, and my guest, Plackis Cheng, the CEO of OpenRad. Okay, Brian, so normally we do this like at the beginning of the show, but we got carried away with ourselves. So what? Let's go back like 1,000 steps. And how did the business OpenRad come to be? What happened? How did it all come together?
Yeah, so OpenRad is a private equity backed company. It's essentially a roll up or a combination of two leading pioneers in the imaging space. So Mark Hole, which is one of the oldest private equity firms based in London, um, built OpenRad by acquiring a company called Visbian, and they were leaders in basically DICOM, both in static centers, but in fleets of mobile imaging trailers. And how do you get these images off of trailers? How do you manage these trailers? How do you monitor these MRI trailers? So Visbian they acquired, and then at the other company, which was really the cloud software, the workflow software, was Biotronics. And these companies have been around 15, 16 years, and they've really been pioneers in doing cloud-based imaging. And it's just taken the industry, I think, this long to really be ready to really move imaging to the cloud.
Okay, and so they were kind of plowing their track, so to speak, and everyone else was sort of like, wow, you guys are crazy, we're not ready for this, and now it's sort of everyone's caught up. Is that kind of the vibe?
Well, there's been regulatory issues around the cloud. There's
Okay.
obviously patient confidentiality issues,
Yeah.
right? So there's been the industry had to catch up. I mean, I've been through this now in several different spaces where the regulatory environment's got to catch up with the technology.
Yeah.
In some markets like the UK, no problem. In other markets, it's still kind of a gray area whether you can really host like a multi-tenant cloud system where you have a platform and you're running multiple customers on the same
Okay.
platform, like a SaaS service. And so this has been really successful in the UK. The other bit is you have to have viewing technology that doesn't require proprietary software. It can just run on the web on any device.
Right.
It's kind of like Netflix. You don't have to load special software for Netflix.
Yeah.
It just streams the bits across. And that's really important because it also helps with regulatory issues because you're not shipping confidential patient data around. It always stays in the server in a secure facility.
Yeah.
And you're just streaming the visual part of the image across the wire. And
Yeah.
these companies were really pioneers in these technologies, and this is really where we have a leadership position. And what we're doing now is taking the company. The companies were primarily in the UK, and they've expanded in over 18 countries,
Oh, nice.
and now we're launching into the US.
Great. Okay. Yeah. So I think just to go back a couple of steps for the benefit of everyone listening, one of the things that Brian's done, and it's a similar approach that we've taken at PocDoc and many other people, which is by keeping as much of your technology, if you like, and patient data in the cloud, in a singular cloud location, and restricting what gets sent down to someone's individual device, whether it's a computer or a phone or tablet, you're able to maintain traceability and control over the aspects of what you do which are regulated and contain sensitive information, as opposed to a system where, which we'll probably all remember, where you had to download a particular piece of software onto your local machine to then be able to do something with it. Then the files are stored locally, or some copy of the files are stored locally. That program may need to be updated. You may not be running the latest version of it, which may alter, etc. It may not contain the latest algorithms or whatever it happens to be. All of that creates a regulatory nightmare. Whereas if you can maintain one copy of everything, one database in the cloud, that makes everything a lot more simple, right?
Yeah, so I can give you an example. So obviously, as one thing you have to do is quality control, right? So you want to audit some percentage of the images, say maybe 3% or 5%. And by using automation and workflow, right, we can do this in a completely anonymous way, right? We can strip out all the patient data, we can strip out all the primary reporting information, and just send this record anonymously to a second specialist who can basically do a peer review, right? And essentially do a quality control, and then we can in the cloud compare those two assessments and figure out how accurate it is, and if it doesn't need to be adjudicated by a specialist or an expert, right? And you can do all that because you can strip away all the confidential information and make that process completely anonymous.
Yeah, exactly. I mean, it makes total sense. Like, you don't. It's in a similar way. The images of our test, PocDoc test, are stored, and they're just an image of a lateral flow test. There's no patient data in that image. So, I think it makes a lot of sense to be able to, because radiologists, they just need to see an image, right? They don't need to see necessarily all of the patient data, metadata, any of those type of things. Obviously, at some point, that has to end up with a clinician or a physician that can deal with that stuff. But you don't need that to be able to look at the scan and say what you think is going on.
So what's exciting for us, and I think this is the opportunity, as you said, kind of the state of the industry is moving to the cloud. It's not easy, right, for customers, for hospitals, for clinics to kind of rip out legacy infrastructure. So we try to layer our software on top, and we become the glue that integrates these legacy systems, disparate MRI machines, disparate patient databases, or storage systems together. But it also becomes a point where we can layer additional innovation. We talked about image enhancement, AI tools. We talked about things like automated flow processes like peer review. You can now accelerate the adoption of innovation in the medical field, right? And that for us is what's really exciting, is as we can get the platform up and running, we can provide that connectivity, then we can accelerate the introduction of new technology. And then I think that gets very exciting because now we can really leverage that cost curve we were talking about before.
Yeah, I think that this is a good, every now and again I have a chuckle about this idea that, the NHS is getting privatized and things like that. And the reality is that people that say that don't necessarily, I don't know whether they know or realize that, like, the NHS, there's a huge amount the NHS cannot do for itself. So the NHS does not make MRI machines. It buys them from private contractors who have their own software. And innovations such as yourself and all the other people that we've had on the show, for the most part, obviously private businesses that are working with the NHS, and the NHS chooses to work with them because the NHS can't do those things for itself. In this instance, it isn't going to be able to develop its own cloud-based system, and it's not a good use of its resources to do that either. So I think it's really, I think it's just another example of how why external innovation can be used to help a national system or any healthcare system.
Yeah, I mean, I think it's like a hand in glove type of thing, because obviously the NHS needs to set the priorities and needs to figure out what kind of capabilities are needed at what capacity. But ultimately, you have to bring the resources together, right? And I think it's an interesting partnership between public and private that can make that happen. And obviously, you got to find the right balance. And in different countries, there's different approaches. Some are much more public, some are more private, some are really hybrid. I think the key, though, is you really want one to motivate providers, right, to really jump into the market, to be well trained, but also you want to also motivate technology companies to bring new technology into the market, right, that can
Yeah,
drive
you have to, otherwise you're
innovative
not going to get
diagnostics and
anywhere.
services and lower
Yes.
costs and all the things you talked about before.
Yeah, there has to be incentive for businesses and individuals to dedicate themselves to bringing innovation into healthcare. There has to be, and like
And there's always some people have a view that capitalism is bad, and some people have a view that public healthcare is bad. But I think it's really how do you get the best out of all these worlds and work together, right? And I
yeah,
think if the mission is clear and the direction and the priorities are clear, and there's a regulatory framework that allows us all to compete in a healthy way, then I think you can have that innovation. But like we talked about at the beginning, we got to get over the adoption barriers that are inherent with the legacy systems and the friction and the inertia so that we can move to the cloud and get all the benefits of AI and automated workflow that can be available in the medical market.
yeah, I would agree. Um, I completely agree. So we are coming into the final few minutes of the show. So what I kind of like to do here, Brian, normally is sort of try and get more of the personal kind of aspect of your journey. Like, so how did you come to end up being involved in this business and leading this business?
Yeah, so I want to give you I guess the 30-second version. So I've been a technologist for decades, primarily in the internet cloud space. Started off as a product person with a phone company several decades ago. Got into the internet space, internet email. Joined a startup, became a general manager. So moved to kind of the business side and
Mhm.
managed the P&L. Moved out to Europe. I'm a New Yorker. Moved out to Europe, built out 18 countries. We took a company public and then sold it. And so that was an amazing experience. And then I started becoming an angel investor myself, and getting involved as an entrepreneur, and then learning how to build companies either as an advisor, investor, or an operator. And
Mm.
along the way, I moved to Berlin with my wife and my family. I started a cycling club for entrepreneurs, and I met the founder of Medneo, which is a very large MRI center operator in Germany and in the UK.
Mm.
And they were looking for a search for a CEO that knew enterprise technology, enterprise software, and it seemed to be a good fit. So I joined the company about 18 months ago.
Oh, that's a great story. How was your kind of transition into healthcare?
Yeah, I mean, I had a little bit of a background because I ran a caregiver marketplace for the last 4 years in Germany. So
Okay.
there was some exposure to it. And a lot of the lessons I learned in moving large images around in email,
Right.
dealing with large pools of freelancers and some other lives, apply really well to radiologists and resources and things like that. But it's nice to be learning and to challenge yourself. And obviously, there's a whole new set of issues, learning about obviously a very technical field, but a field that is life and death, and the
Yeah.
stakes are much higher.
Yeah. And we've got 2 more minutes before we have to cut off. So very quickly, what advice would you give to entrepreneurs in the health tech space generally? What's kind of got you through?
Yeah, so I think one is obviously, you need to have passion about a problem, right? So somewhere in your life you're exposed to a problem, and it has to be big enough to worthy your time and your attention, right? The second thing is you have to have an approach that drives innovation, and so I used to do a lot of advisors for like startup boot camps and things like that, and you have these really smart kids, but they don't have a great idea, and
Right.
sometimes you need to go into the market and learn how it works, join companies like ours and more established companies just to learn about the challenges, the problems, the solutions, and build a perspective, but also maybe a network in the space. And then I think you start seeing the pain points because in every industry there's so many pain points, and something that really tickles your fancy, and you say, "Hey, wow, I have a lot of passion around solving it." So I think finding a problem worth solving is the trickiest thing, but the most important thing for any entrepreneur. Yeah.
Well, look, Brian, I completely agree with you. And on that note, thank you very much for coming on the show. Brian, Plackis Cheng from OpenRad. And thank you to everyone for listening. We'll be back again next week.
Thanks for having me.